some of the next. On this diagram, you can see the normal middle ear. What kind of view of the normal ear? You know, ear is located in temporal bone, and it covered with the lining. It is mucosa, which started from the nasopharynx. On first lectures, I told about that. And this mucosa lining through the eustachian tube lies all the structures of the middle ear. And the ossicles also covered with this. In infected fluid, when will be present in middle ear, you can see that view is like that. And of course, among of the walls of the tympanic cavities and the middle ear, the weak places, it is the lateral wall. This is the tympanic membrane. And you can see on these pictures that tympanic membrane is hyperemic, edematous, and bulges to the extra-auditory meatus. Depends on the fluids and pressure, which increases in the middle ear. Okay. Next, what about the bacteriology? Which bacteria is most common in acute otitis media? Mostly it is Streptococcus pneumoniae, 48%. H. influenza also, 31%. Moraxella catarrhalis. This is 3 main microorganisms which causes the acute otitis media. Others also will affect also, but rare. Pseudomonas aeruginosa, uncommon cause of acute otitis media. Streptococci, Staphylococci, Pneumococci, E. coli, proteus, and viruses of various respiratory diseases. After that, you can understand why the viral infections, which are located in the upper respiratory tract, can involve in this process of the middle ear. Viruses also will be rhinosinus viruses. 74% of middle ear isolates. Rhinoviruses, parainfluenza virus, influenza virus. Okay, now. Okay. Next, route of infections. Okay, how infections can spread to the middle ear? Of course, first of all, via eustachian tube. Depends on anatomy, you know that eustachian tube, it's communicates with the nasopharynx, which opens on the lateral wall of nasopharynx, behind of inferior turbinate, 1 centimeters away from posterior end of inferior concourse. And these infections can spread if the patient suffers with upper respiratory tract infections, acute rhinitis, and nasopharyngitis. It's acute process in nose. This is the pharynx, nasopharynx. Next, upper respiratory communicative diseases, diphtheria, measles, scarlet fever at all, swimming and diving in unclear water, and anatomic contribution. This is the etiological factors, or we can tell predisposing factors, which help to help for microorganisms which can spread to eustachian tube, and after that infected other structures of the middle ear. Okay, this is the connection of the middle ear with nasal cavity and nasopharynx. This is the one of the structures of middle ear, tympanic cavity. It's visible part. This is otic. And posteriorly, Otitis, which communicate with antrum, and mastoid ear cells. This is a eustachian tube of the adult. And if we perform the posterior rhinoscopy, this is the uvula. This is the posterior ends of 3 turbinates of the nasal cavity. And you can see this is the openings of eustachian tube. And you can see this is the soft palate structures. During swallowing, yawning, opening of our mouth, when the muscles of eustachian tube constrict, for example, and which attends to the soft palate, some case, for example, levator veli palatini, tensor veli palatini, tensor tympani muscle also of the eustachian tube muscles. In this case, the eustachian tube open and close. And normally, in nasopharynx, this also microorganisms is present. It's not sterile condition. But in middle ear is sterile. And we told that mucosa linings which started from the nasopharynx through the eustachian tube, it lies all the structures of the middle ear. And of course, will be some of specialties because of acute otitis media, most common in children, and this is in childhood mostly acute otitis media present. Why? We told one of the etiological factors, this is the anatomic contribution. And in adults and in children, what kind of the differential some of the signs is present. For example, eustachian tube, it has 2 ends. Yes, this is the cartilaginous part, and this one, it is the bony part. And in adults, anterior two-thirds cartilaginous, and mostly part is cartilaginous. In children, longer bony portions. It means that bony, it's not constrict and not close. Yes, that is why in children, mostly it's opening the eustachian tube. Posterior part in adults, 1/3 is bony part. 45-degree angle in adults, and in children, 10-degree angle, more horizontally. Isthmus, 1-2 millimeters, means that narrowest part of the eustachian tube. For example, it's located between the bony and cartilaginous part is isthmus, and in children, isthmus larger. Nasopharyngeal orifice is 8-9 mm, in children 4-5 mm in infants. Okay, this is the ear of adult ear, and this one is the baby's. It is external ear and external auditory meatus. And in children, you can see this is the very narrowing and sometimes not visible, the tympanic membrane. Sometimes we can't check the tympanic membrane because external auditory meatus can blockage by the myxoid tissues, amniotic, some of the tissue fluids, and this. Okay. Second route of infections via external auditory meatus, external acoustic canal, and tympanic membrane. For example, traumatic perforation, yes, of the tympanic membrane. And I have a question. In your mind, this tympanic membrane, it is right or the left tympanic membrane? If you have some of opinion minds, you can write to chat. And I will continue. Okay. And I have one right. Somebody's who has some of the opinion? If you remember, on first classes, I showed two tympanic membranes, and I told that depends on the handle of the malleus and cone of light. If located on the anterior inferior part and at the position of the 7 o'clock, it will be left tympanic membrane. Yes, this is the left tympanic membrane. Yes, of course. And we told that when we divide on 4 quadrants, anterior, inferior, mostly weak places of the tympanic membrane. And you can notice this is the perforation occurs in anterior, inferior quadrant. Yes, mostly students wrote me left tympanic membrane, yes. And via external acoustic canal, the infections also can spread because external acoustic meatus, so it's also some of the on the skin is some of microorganisms present, and maybe patients swimming and diving in contaminated water, and through this perforation, water can affect the middle ear via blood supply also, but it's very rare via blood supply, very rare. Okay. What about the pathology? How is pathogenesis of the inflammation? First of all, will be inflammation of the mucosal membrane of the auditory tube and tympanic cavity. Yes, it's characterized by edema and, inflammations characterized by infiltration of leukocytes. Yes. After that, filling the cavities of the middle ear with exudate, which is initially can be serous and then acquires a purulent character. Maybe only serous and not has passes. If the pus will be liquid, thick, viscous. As a result of intense pressure of purulent exudate and circulatory disorders, perforation of the tympanic membrane with subsequent otorrhea. Otorrhea means that discharge from the ear. Otos is ear. The rhea is the liquids, yes. Mucopurulent discharge gradually becomes thick, purulent, and as the inflammatory changes subside, their number decreases and suppression completely stops. The perforation of the tympanic membrane may close. This is the pathogenesis, but sometimes final stages, resolution stages, can maybe not present, but rare. It may be complication. Complications characterized by two ways. One is characterized by resolution. Second one, lethal outcome. Now, of course, very rare, but before, when developed the antibiotics, you know that first antibiotics, who described the first antibiotics and, for example, penicillin from the histories. Who firstly described this penicillin and who has some of the opinion? I can see Gentamicin. Gentamicin first. Next, any some of the opinions who has? Okay, you can write me, and after that we will tell. Okay. About classification. Which classification? Penicillin, yes. Who firstly described penicillin? Please, without Google, Wikipedia. Yes, penicillin first. Yes, Fleming. Yes, Fleming firstly. Yes. Before opening of the antibiotics, mostly patients can die after this otitis media. And yes, I'm glad to see your feedback, really, because only listening, of course, sometimes difficult, and some cases I can see your feedback, and I'm glad to see. Okay, good. What about classification? Acute otitis media, we can call it if the complaints of the patient's clinical features, its duration will be approximately 3 weeks or 1 month. We can call it is the acute otitis media. If it will be prolonged during 3 weeks to 3 months, it is subacute otitis media. 3 months or longer, we can call this is the chronic otitis media, chronic case. Okay. Next, what about the stages of acute purulent otitis media? Stages of acute purulent otitis media. First stages, we told if the route of infections most common via eustachian tube. First stage is characterized by tubal occlusion or acute eustachitis. What kind of complaints patient has first of all? Blockage of the ear, discomfortableness, otophonia. Otophonia, it means that patients during speaking, he can hear his voice in ear. And we can call this is the acute eustachitis. And also patients can has the earache because the negative pressure forms in the middle ear, and on otoscopy we can see the tympanic membrane retracted to the tympanic cavities, and the landmarks of the tympanic membrane will be absent. For example, one of the landmarks on first classes we told, this is cone of light, yes, and in eustachitis or tubal occlusion, this cone of light will be absent or more horizontally and shorter. Okay, next stages, it is the yes, by curve of tympanometry, yes, we also can tell because the tympanometry or impedance audiometry usually ear, yes, dysfunctions of the auditory tube or the normal, you know, this is 80, yes, and if some of the problems will be, of course, this is the diagram will be different, and tympanometry, of course, it is the help for the diagnosis. Okay, next, cateral inflammation. Third one, it is pre-perforation stages. Next one, perforated and reparative. Next, we described all the stages. For example, acute otitis media on otoscopy, we can see the left, it is pre-perforative stages. You can see this is the congestion of the blood vessels. This is the blood vessels also inflamed, and the tympanic membrane also supplied. Yes, and you can see this is the tympanic membrane bulges to outside. And this is the perforated stages. You can see this is the pulses and pulsatile pulse. Sometimes it depends on what is it pulsatile, because the internal carotid arteries, it is anterior wall of the tympanic cavity, and depends on the pulses. The pulses can through the perforations to outside moves. Okay. This is the symptoms and signs of acute otitis media. Earache, yes, we told. Disturbed sleep, deafness and tinnitus, fever in children and restlessness, signs congestion of pars tensa, flash of blood vessels appear along the handle of malleus, cartwheel appearance, and tympanic membrane become red. What about the physical findings? Of course, very important to put the diagnosis otoscopy. Otoscopy shows the tympanic membrane, what kind of, and depends on the view of the tympanic membrane. Also depends on the complaints and anamnesis. Always help for the put which stages of the acute otitis media. And this is, you can see, this is the tympanic membrane. Normally it has pearly gray, yes, color, pearly white color. And in these pictures, you can see this is the tympanic membrane is hyperemic. Yes, hyperemic. And also the skin of external auditory meatus also hyperemic. And the pars flaccida is bulges out, because you know that fibrous layer of the pars flaccida is less, and this is the bulges out. Next, this is the also, yes, yes, good. Okay. The tympanic membrane also, you can see this is the bulges. Yes, bulging, bulla formed. Yes, really. Rapid middle ear exudation occurs, blurring of the middle wall short process, followed by edema and bulging of the pars flaccida. The next view, what you can see here, this is the tympanic membrane, this is handle of malleus, and in my mind, this is the left tympanic membrane. And what you can see, this is the perforation. Yes, this is perforation occurs. And progression of the disease may result in rupture of tympanic membrane, releasing the middle ear contents. Beating sign leads to relief of otalgia and retraction of the pars flaccida. In perforated stages, when the perforations of the tympanic membrane occurs, all the symptoms relief, temperature decrease, pain relief, some of the earache also relief, headache relief, but new symptom, it will be ear discharge, and pressure will be decreases. That is why this is the passes will be, we told, mucopurulent, yes, the liquid, but sometimes together with the blood, because the tympanic membrane, you can see, is supplied, yes, and when it will be damaged, the small arteries and veins also damaged, and together with the blood will be present. Okay. What about the hearing test? Of course, before the audiometry, we can use other tests. This is the speech test, tuning fork test. Yes, tuning fork test. And if you know conductive hearing loss, if it will be, it means that yes, ABC test, Weber's test, yes. Yes, of course. First one, we perform the Rene test. Yes, Rene test, when we compare between the air and the bone conductions. You know that we have two ways of conduction of the sound. Yes, it will be which conduction of the sound will be through the air and through the bone. Yes, finally activate the hair cells which located in cochlea. Yes, in internal ear. Okay, now somebody's right. Yes, bone and ear conductions. Yes. Usually bone conduction shows what happens in cochlea because directly it stimulates the hair cells. Conduction of the sound or conductive hearing loss will occur until vestibular stapedial joint. Until vestibular stapedial joint means maybe external acoustic meatus, obstructed perforation of the tympanic membrane, or the fluids in the middle ear, or discontinuity of the chains of ossicles. And in this case, air conductions will be decreases. Bone, it will be on the same places. But normally, you know, air conduction is better and more than bone conductions. But in conductive hearing loss, in Rene's test, Rene will be negative. When the bone conductions, it will be more than air conductions. What it is Weber's? When we vibrating tuning fork, we place on the forehead or the vertex, yes, and in a patient with acute otitis media, it's lateralized to worse ear. Which ear is affected to this ear is lateralized. ABC test, it is absolute bone conduction. Mostly we perform to check the cochlea's functions. We vibrating tuning fork we placed on mastoid, but external acoustic meatus must be occluded. Yes, occlusion. And we compare between the examiner, but examiner must have good hearing. And if it will be, for example, in sensorineural hearing loss, when the cochlea affected in this case, this is the reduced or shorter ABC test. In a patient with the Schwabach test, it's the same, but we not close the auditory meatus. We compare the same. With sensorineural hearing loss, it will be reduced. In conductive hearing loss, it will be prolonged. Okay. In being test, vibrating tuning forks we place on mastoid and alternatively open and close external auditory meatus. And we ask patients what kind of differences when close and when it open. And patient with conductive hearing loss, for example, with acute otitis media, for example, yes, it's not changes. When we place open and close, who has conductive hearing loss, no any some of the differences. Okay, and audiogram, audiometric test. What it shows audiometric test? You know, the right ear we marked mostly with the red pen. by blue pen. And this is the air conduction, and this is bone conduction. Normally we can hear between until 20 decibels. This is the normal. This is the frequencies. Yes, we start from the 125, 250, 500, 755, and until 8,000. Yes. For the speaking, we use conversational speech. Mostly is from 500 until 2,000. This is the measure for the conversational speech. Yes, and we use like that. In conductive hearing loss, you can see the bone is normal, a little bit maybe on the high frequencies, a little bit decreases, because it depends maybe labyrinth irritating of the labyrinth, because it's near located of the tympanic cavity near the middle ear. Yes, but air conduction, you can see it decreases. Yes, and you know that degree of the hearing loss, 20 until 40, it is the mild. Yes, stages, first stages, it is mild hearing loss conductive. 45 until 60, it is the moderate. Next, 65 until 80, 85, it is severe. It is third stages of hearing loss. And below it is the profound or the total deafness. And in this, you can see on left ear, between the second and, yes, between the second stages of acute otitis media. Okay, degree of hearing loss will depend on the amount and viscosity of the middle ear exudate, tympanic membrane edema. It varies from 10-50 decibel with predominant involvement of the low frequencies. And hearing loss may mix it when end bone and the air conductions decreases, but between air and bone will be gap is present 10-20 decibels. Hearing loss may mixed when there is labyrinthine extension. Okay, what about the lab test? Lab test, you know, inflammatory process shows the leukocytosis, yes, with polymorphonuclear elevation. CT and MRI, not every time we perform, they are necessary only for the rare patient with the serious complications, for example, meningitis or the brain abscesses. Okay, what about the management? Of course, it is acute inflammation, and we use antibiotics, which covering the Streptococcus pneumonia, H. influenza, Moraxella catarrhalis, and it includes which antibiotics mostly? It is amoxicillin, clavulanic acid, yes, penicillin, but mostly we use the amoxiclav or the augmentin. This is the amoxicillin and clavulanic acid because they are oral beta-lactamase resistant. Or we can use the cephalosporin group of antibiotics and or the macrolide. For example, azithromycin, clarithromycin, yes, roxithromycin, and others. And I have a questions in your mind. How we can use the antibiotics? Which way we prefer? Oral or IV or IM? Because the same diseases in different patients will be different. That is why we have to individually we have to choose antibiotics, because sometimes patient has allergy as for the penicillin group, cephalosporin group of antibiotics, and we have to use macrolide. And in your mind, how we can use the antibiotics orally, IV or IM? If you have some of opinion, you can write me orally. Так, okay. Why we use oral? Have you got any some of ideas? Yes. Of course, when we choose antibiotics, we have to see patients, yes, the clinical features of diseases. Sometimes it's characterized by complications. In this case, we have to use IV. And sometimes one antibiotics will be not enough, and we use combination of the antibiotics. For example, for example, not all the antibiotics can spread to the CSF, yes, spaces, CSF, because if the patient has meningitis, for example, otogenic, it means that primary was the ear disease, and after that complicated by meningitis and the brain abscesses. In this case, of course, we have to use not only one antibiotics, high doses of, for example, penicillin, because till now penicillin has a can spread to the CSF, and you know that we use it every 4 and 6 hours, yes. And for example, if acute otitis media without complication, usually we not hospitalize this patient, and 4 times in a day with these antibiotics, of course, will be painful, yes, for children. We thought most common in childhood, and that is why it's individual. Sometimes infants, children has the vomiting, yes, vomiting, because the you know that sutras petra squamosa, it means that temporal bone, yes, petras, it is the petrosal part of the temporal bone, and the squamosal part of temporal bone is not properly occluded, and these passes, which located in middle ear, it can irritate the meninges. During this, patient has the symptoms of meningism. It's not meningitis, but symptoms of meningism. It's rigidity of the back muscle. Next, also has the vomiting, also has the okay, and vertigo. In this case, we use the IV. For example, maybe cephalosporin. Cephalosporin we can use 2 times, sometimes 1 time we can use. Okay, about decongestant drops. How we can use it? Of course, to nose, yes. On beginning of our lectures, I told anatomically where located the eustachian tube, and mostly patients, if they don't know, of course, where located, yes, and use it like that, yes, put to nose, and that's all. It's through the wall, floor of the nose, it comes to the throat, and that's all. But you know, it's located on the lateral wall, yes, and your nasal drops not help for the decrease the edema and hyperemia of eustachian tube, because the successful treatment of the middle ear infections depends on good functions of eustachian tube. which is the functions. It is ventilation function, yes, it's the drainage function, and it's the protective functions. And of course, we have to ventilate, yes, to improve, because the tubal occlusion, and we should open the eustachian tube, we should treat, and we have to use like that. We turn head to affected side, put the drops, 2-3 drops of the nefazoline or xylometazoline. This is oxymetazoline. This is the help. Yes, it's formed the small lake around the orifice of eustachian tube, and it's helped to decrease the inflammation of the eustachian tube. Usually we use 3 times in a day, not more than 7 days. Of course, in children, the doses of these drops is the less. For example, in adults, 0.1% of, for example, nefazoline. Children until 1 year, it will be 0.025%. It means that one is further, is like that. In children who until 6 years, 0.05%. Okay. And I have a question. For example, patient has unilateral acute otitis media. Not every time will be bilateral processes, yes? And patients can ask for both nose use these drops, or only to one nostrils, because only one ear affected. And doctors has some of opinion, and I will tell after that. But I want to ask you, in your mind, patient has unilateral acute otitis media, and nasal drops we use only to one nostrils, to one nasal cavity, or for both we use. Who has some of the ideas? Please write. And after that, I will explain in which cases we use in one nostrils, in which case we use in both. Now, some of the, it starts from the nasopharynx, yes? And it lies in eustachian tube. Through the eustachian tube, it covers the structures of middle ear. And route of infections, also we told 3 main route of infection, but most common, it is eustachian tube, yes, by eustachian tube. And of course, it was some of, and also we have a chances that other ear can be affected. That is why if the route of infections was via eustachian tube, we use both sides, both nose, because the for prophylactic aim, other ear also must be ventilated good, and the good functioned. But if the route of infections was via external acoustic meatus, in this case, we use only one side. Because, for example, traumatic perforation of the tympanic membrane, yes? And so we use only one side, not both sides. And before perforation, we use drops which contains the anesthetics, for example, because it's pain, yes, otologia, it's present. When the pus is formed, in this case, we use oral toilet, or we have to remove the pus, and to use the drops which contains the antibiotics and corticosteroids. Which antibiotics? Mostly we use quinolone, fluoroquinolone group of antibiotics like ciprofloxacin, ofloxacin, levofloxacin. This is the drops to the ear. And of course, analgesics. This is the treatment. Of course, I told main treatments, yes, general, some of the therapeutic approach, but treatment depends on the stages. It's a little bit differentiated. For example, perforation stages, before perforations, we use antibacterial therapy, local and general anesthesia, restoration of the functions of auditory tube, means the drops, nasal drops, yes, anti-inflammatory drugs, if indicated, paracentesis, because we can use the incision for decrease the pressure, and immunocorrection. Treatment of acute otitis media in perforated stages, also continued antibiotic therapy, oral toilet with sterile warm solution of the extraordinary meatus, and next drugs, we use drops which contains the antibiotics, nasal decongestant also, yes, and indications for paracentesis. Which indications? If severe pain in the ear continues, high temperature persists, with otoscopy protrusion of the eardrum is observed. Because in this case, signs of irritation of meninges appear. How we can see that irritation of the meninges? We told you this is the rigidity of the back, next vomiting, nausea, next it's Kernick's or Brudzinski signs also it can be. The process extends to the inner ear. And how we also can understand dizziness, nausea, and vomiting, ataxia, spontaneous nystagmus. And there is paresis or paralysis of the facial nerve, if it will be, it develops periostitis of mastoid process. This is the paracentesis of the tympanic membrane. Mostly we perform on posterior inferior quadrant of tympanic membrane. First of all, for good drainage, yes, because the inferiorly we drain the middle cavities, hypotympanum and other structures of the middle ear, and posteriorly, because the anteriorly mostly the ossicles is presented. To avoid of the damage of the ossicles, we perform here. This is the possible outcomes of acute Pyrlontotitis media. Of course, it's the different types of the will be it's recovery, of course. The maybe chronic, yes, it's turned to the chronic. Development of the complications, yes, it will be mastoiditis, labyrinthitis, facial paralysis, intracranial complications, and formation of adhesive otitis media. This is the complications. And mastoiditis. Mastoiditis, it will be acute and chronic. What about acute? It is results of an infection that extends to ear cells of the skull behind the ear. Until 3 years of the patient, we can call the mastoiditis, because the mastoid process are not developed in infants and in small babies. And we can call on the otoenteritis, antrum and the ear involved. But after that, mastoiditis can be occurs. This is the structures of the middle ear. This is the pneumatic type of the mastoid process. This is the facial nerve, you can see, yes. This is the foot plate of the stapes here. This is the stapedial muscles. This one, it is the prominence of lateral semicircular canal. This is the tensor tympani muscles. Yes, this is eustachian tube. This one, it is the plexus tympanicus, which formed by nervus tympanicus of Jacobson nerve and together with sympathetic plexus. And you can see this is all the structures is located near, yes, and that is why it may be paralysis of facial nerve, yes. This is the semicircular canal. Sometimes will be distraction, and usually in chronic case, patient has fistula symptom, positive fistula. What is it? When the tragus, when we press it, and the fluids, if present, for example, drops we put to the ear, or the maybe the during oral toilet, some of the fluids, or the air can maybe spread through the lateral semicircular canal, irritate, and patient has the vertigo and vomiting and this. Okay, this is the, because near all these structures is located. What about mastoiditis etiology? H. influenza, Haemophilus, and Streptococcus. Untreated may spread to surrounding structures, brain caused by untreated acute otitis media. And you can see what kind of view will be. For example, this is the mastoid behind of the pinna is located. And if infections, you can see this is swollen area, hyperemia, and when it's palpated, it's painful, very painful. The ear position of the external auditory position of the pinna will be turned forward, and visually we can see asymmetry of position of the pinna. And the symptoms, of course, pain, tenderness, ear pain, fever, headaches. And you can see like that view. Yeah.